Kirana, Kirana, Kirana. Bagaimana nak kamera dalam dia? Hah? Mimurke. Peşinler tabii çıkıyor. क्लास क्लियर देता समझ अब 7 दिन कोई मना कर नाना मत गाली कर नंबर का नहीं नंबर अरे हाँ चलो मोर भी अच्छे होना मुझे बढ़िया फ्रेंड्स मैडम कैमरा मैम Opposite side. All.
Today's scientific sessions, we invite you to settle in, engage deeply and make the most of everything OSOCON has to offer. So I'd like to request the moderator for the first session, Dr. Pranamita Pujari, to take over.
To come forward, Dr. N.B. Rao sir and Dr. J.C. Dar sir. And our first participant is Dr. Sadhya Satapava. Please know.
A very good morning to everyone. The clinical significance of pressure to cornea index in primary open-angle glaucoma, normal tension glaucoma, ocular hypertension and normal individuals, a comparative analysis. Good morning, I am Dr. Shraddha Shatapada from JP Rotary. I am going to present this topic. The slides are not moving. Cell loss. Over the past decade, IOP and CCT have emerged as independent risk factors in both glaucoma classification and progression, and a positive linear correlation between where tonometry is unreliable, and to evaluate whether significant demographic differences across diagnostic groups affect PCI values. So we conducted this study for 1 year, which was a longitudinal, non-random and age distribution according to that diagnosis. We found that the mean age was highest for POAG followed by NTG, and males and females were 50% equally distributed within OHT and POHT. The cutoff ratio differed significantly, with the mean CDR lowest in OHT and highest in POHT. Visual field defects were there in 95% of the NTG and POG patients and only 10% of the OHT. We found that the mean IOP was lowest in NTG and highest in OHT, followed by POG. and ours is a longitudinal study with the highest POG followed by OHT in the PCI trend, and the mean PCI was also the same, and as per their conclusion, we found the upper limit of normality similar to that study, proving this to be an intracontinental study. The correlation analysis was also significant. We found strong positive correlation between IOP and PCI and negative between CCT and PCI. And yes, it was a promising utility as an independent composite marker for both diagnosis and progression of glaucoma, CCT and IOP alone. Thank you so much. And ours is a longitudinal study. Then we included the demographic factors like age and sex differences between the different ages. About the structural defects and with the optic disc findings, we also took upon the functional aspects as well.
What is the importance of the corneal thickness in ocular hypertension? Immediately, how much importance should you give to the corneal thickness in ocular hypertension?
So usually corneal studies, so we have to...
Not necessarily.
Sir, as reports, the mean reports say OHT patients have relatively thicker corneas than POEG and NTG.
So why did you exclude PACG from your study?
Sir, and we hadn't started the anti-glaucoma drugs because in PACG often patients come with acute attacks and the corneas are often hazy, and IOP underestimation or overestimation is also possible, so we excluded PACG.
So this is the first one. Still it counts.
Usually open angle patients don't have hazy corneas, usually sir. So we gave them the anti-glaucoma.
How do you correlate CCT and IOP? Is there any formula is there?
Yes ma'am, we have the CCT, the regression formulas.
Any other way, like in generalized, how CCT and IOP is correlated?
Ma'am, we have the app-based formula which is already there in the pachymetry. It gives the CCT, CCT guided IOP.
Suppose there is 100
I am Dr. Siddharth from the Institute of Medical Sciences, and today I will be presenting our paper on the qualitative and quantitative study of ocular surface changes in glaucoma patients on long-term therapy. These are my co-authors. And most of the glaucoma patients require a lifelong IOP lowering therapy. Long-term use of these preserved glaucoma medications can lead to ocular surface toxicity, as these contain benzalkonium chloride, which is well known to destabilize the tear film, reduce the goblet cell count, induce conjunctival inflammation, and also contribute to meibomian gland dysfunction. We used to assess symptoms the ocular surface disease index questionnaire, which gives us a reliable subjective measure. The aim of our study was to evaluate the ocular surface changes in glaucoma patients on chronic topical therapy. We used the Sherman's test to quantify the tear secretion and the OSD score to get an assessment of the symptom severity. We included all glaucoma patients on topical anti-glaucoma therapy for more than 6 months. Our study was a hospital-based cross-sectional observational study of 6 months duration. We divided the patients into monotherapy and combination therapy groups, and sample size was 50. We assessed the patients for symptoms of dryness, burning, foreign body sensation, watering, and visual discomfort. We measured the IOP, the Sherman's test, and Sherman's basal. The patients completed the OSD questionnaire, and we also documented the different classes of drugs used, and severity grading was done based on Sherman's and OSD score. So here in this table, we see when comparing the mean of the ocular surface parameters between the combination and the monotherapy groups, tear secretion is reduced and OSD scores are slightly higher in the combination therapy group, but it is not statistically significant. This is the bar chart of the same. But here in this table we see when we are comparing the parameters between different drug classes individually, as the number of drugs increase, the tear secretion reduces and the OSD score increases. In our study, PGA monotherapy demonstrated the best ocular surface tolerance. Clear correlations. Higher IOP was associated with higher OSD scores, meaning a more severe disease requires a heavier drug burden. Sherman's 1 and basal values showed a strong positive correlation, confirming rating scores, higher OSD and reduced tear meniscus height in glaucoma patients on chronic long-term therapy. Most importantly, these changes, as suggested by these studies, are reversible with the addition of supportive therapy like lubricants or cyclosporin or converting to preservative-free regimen. To conclude, chronic topical anti-glaucoma therapy significantly affects the ocular surface, tear secretion decreases and the symptoms increase in direct proportion with the drug burden. Simple tools like Shermer's and OSD can help in early detection, and switching to preservative-free regimen and tear substitutes can improve the patient comfort and adherence. Thank you.
Thank you.
Is only test tools can depend or on OSD.
Sir, actually,
Can you go for a little more accurate test?
TFL breakup time. This is just Shermer's basal, and we are giving the questionnaires to the patient.
So why didn't you include the TFL breakup time? But anyway, you are concentrating only on preservatives. What about the original medication, the parent medication itself? Can it cause corneal?
Sir, actually, that is the plan.
Then how do you coordinate it? Because preservative and preservative, right? So that you are concentrating only on preservative, not on medication, the parent medication. So how do you give the accuracy? Because it is because the preservative, not because the drug itself.
Other corneal problems which might come across.
Sir?
You have only taken into consideration, or your study was based on TFL?
Shermer's
test. But what are the other ocular surface changes which you might come across in these cases?
There is allergic conjunctivitis, folliculitis. These things we are excluding. So only the eyes which are quiet, those we are taking for the study.
There are the eye drops which we use.
So,
Other preservatives other than BAK. Okay, thank you.
thank you.
Yeah.
The topic of my presentation is determinants of late presentation in newly diagnosed glaucoma patients at a tertiary care center. My mentor is Professor Dr. Sumita Mahapatra. Slide is Glaucoma causes irreversible blindness in 4.6 to 6.7 million people globally. Around 10 to 33% patients present with advanced disease and visual impairment at first diagnosis. Late presentation common due to minimal or absent early symptoms, as glaucoma is called silent thief of sight. Late presentation is a major risk factor for glaucoma blindness and limited treatment benefit. Aim of my study among patients 55 cases, out of which 40 patients are late presenters, that is 23 cases. Inclusion criteria: patient diagnosed having glaucoma for the first time in our OPD. Late presentation is primary or secondary glaucoma, having either glaucomatous visual field loss within 5 degrees of fixation in at least one eye or damage in both upper and lower hemispheres. Vertical CD ratio more than 0.8 in at least one eye with field loss. These are my exclusion criteria. Clinical evaluation: after taking patient's demographic details and thorough history, comprehensive eye examination done with BCPA recording using Snellen's chart. Of 16 years, male is to female 1.87 is to 1. Among all the late presenters, 27% presented with student agree with different other similar study finding. Increasing age showed a strong association with late presentation. Rural residents had a higher likelihood of presenting late. Although most of the late presenters had no family history, even with positive family history presented late due to poor glaucoma awareness. Present late due to unawareness, socioeconomic barrier and diagnostic delay. Enhanced training for optometrist and ophthalmic assistant is essential, as many a time they are the first point of contact. Addressing modifiable determinants, especially poor awareness, misdiagnosis, should be prioritized to achieve equitable.
which makes them present late. But what is the one factor which is very important to make them present late? I mean, they don't present late. It's usually seen on routine examination.
Sir, actually most of the people are aware about cataract. They just visit the hospital just for eye checkup if they had cataract or not. But at that point of time, the ophthalmologists who are doing their eye checkup should do a comprehensive eye examination campaign for cataract.
No, that's not the point. That's because they are aware of the visual deficit. And glaucoma, as we all know, is a silent killer asymptomatic. That's what I wanted.
Dr. Suprabha, I think this is a tertiary care statistics. So how does it reflect the general population, and what will you do to detect those cases in the general population?
What clinical factors, what demographic details, what socio-economic factors are responsible for the late presentation, and accordingly we aim to improve our early diagnosis by targeted screening and increasing awareness and timely referral of the patient, by which we will subsequently prevent the glaucoma related
What do you mean?
On like advanced glaucoma, so how glaucoma is classified, mild, moderate, severe, advanced? According to Glaucoma Association guidelines.
the mean deviation less than -6 decibel, moderate is mean deviation -6 to -12 decibel, and severe is more than -12 decibel. And in severe glaucoma, the central visual field 5 degree of fixation, in the 5 degree of fixation loss present. In mild glaucoma, the field loss is not that significant.
To consider these factors while doing the study and this thing, I think you concentrated more on curved X ratio, I guess.
No ma'am, with curved degree fixation loss, we have considered them advanced cases, and also those who have both upper and lower hemifield visual loss in one or both eyes. We had taken them.
Today I am going to present the traumatic glaucoma, insights from a case series in a young and working age population. Introduction: the traumatic glaucoma is significant cause of secondary glaucoma. Mainly it involves angle recession, hyphema and lens-related mechanisms. It's more common in young and working adults due to occupational and accidental injury. Early diagnosis and management prevent irreversible vision loss. It mainly includes two types: blunt trauma and penetrating trauma and chemical trauma. So, blunt trauma results in inflammation, hemorrhage, lens-induced and angle recession. Penetrating trauma, epithelial downgrowth and intraocular foreign body and chemical injuries. And early onset is mainly due to lytic, intraocular foreign body, ocell, cyclodialysis, RD and epithelial downgrowth. The aim is to study the clinical profile, mechanism and visual outcome of traumatic glaucoma. It's a prospective observational study, duration of 2 years, sample size was 27 patients, detailed history with slit lamp evaluation, bonioscopy, applanation, tonometry and fundus evaluation was done. It mainly include 22 males and 5 females. The type of trauma being blunt and penetrating. So the major cause was the angle recession glaucoma. Secondary glaucoma due to hyphema was the second major cause, and lens-induced glaucoma. So mainly the management. The goals was to reduce the IOP, treat the cause and prevent the optic nerve. And in acute IOP spikes, mannitol was given to reduce inflammation. Steroids, prednisolone and cycloplegics like atropine 1% was used. In case of hyphema related to IOP rise, myotics are avoided. Surgical management for angle recession, argon laser trabeculoplasty for recession less than 180 degree and selective laser trabeculoplasty for 360 degree when angles allow. The surgical procedures include trabeculectomy, extraction with phaco, ECC and PPV when needed was done, and post-op care with steroids, cycloplegic and IOP monitoring was done. The results and outcome: the functional vision was more than 6/18 in 14 patients, that is 51.9% patients. Moderate vision 6/60 to 6/18 in 7 patients. Severe vision impairment less than 6/16 in 6 patients. The angle recession was the most common and late cause. Majority achieved stable.
Hyphema, and how will your treatment how will you decide to treat according to the grade of the traumatic?
It's less than 1/3 of the corneal height.
we'll wait and watch. We'll try to control the IOP. We'll give the medical management and we'll wait. If still the hypema doesn't resolve or the pressure is not resolved, then AC wash can be done. But we need to wait for pressure more than 50 if it's not it's an uncomplicated case. We wait for 5 days. If it's a complicated case or rebleeding occurs, if the pressure is more than 25, and we need to wait for 3 days. And if the pressure is very high and we have so bleeds mainly occurs. We need to rule out sickle cell diseases. If sickling is present, there is increased risk of bleeding. And immediately we need to manage.
What is the most important cause of trauma in female, and what is the most important cause of trauma in male in your situation?
Sir, most assault cases are due to fist or fist injury or due to blunt stick injury. In case of males and females, trauma due to hand while the children while playing.
It is a hospital-based study.
Outdoor OPD based.
Your age group distribution and how all the patients responded to treatment, what was the time of presentation and how many patients underwent for surgery and which surgery. I would have loved to see that statistic part also in your presentation.
Patients were workers. The workers who one had injury, the total hypema photo which I have shown, he had injury from the wall on his eye.
Okay.
He presented late. So after 4 weeks around, so he had developed, the clot was there, IOP was high, AC wash was done, and mild corneal staining was there. So we waited and we did PK for that patient. And in
PK, whatever. Thank you. Time is at 10 minutes, that's why I'm asking.
We have to suspect that this patient has glaucoma. Suspicion either is the intraocular pressure suspect when the pressure is consistently high, higher than 21-22 millimeters. This is IOP suspect. There may be a glaucoma disc suspect. If the disc is say more than 5 or more than 6, you start suspecting. Then you start taking your history, family history of the glaucoma and other factors. Right, but once you see that the glaucoma just copying is what is more often taken into consideration, 0.5 to 0.6 is just borderline. 0.6.
Do you treat glaucoma patient on the basis of OCT changes, sir?
No, strictly no. Strictly no. You depend more on visual field rather than OCT. OCT, there may be green disease, there may be red disease, and with a normal glaucoma, no glaucoma.
The zone to control the intraocular inflammation. So there were spikes in intraocular pressure in 4 of our patients.
so how did you manage them?
All the patients were effectively managed with topical.
Good morning everyone. Today I am going to narrate a story. The story of a fever that didn't end with the fever. The story where vision slowly slipped away and our diagnostic and therapeutic guardians came together to win it back. This is my case series on post-fever retinitis. In our story, we have 6 main characters, young individuals, all of them presenting diminution of vision and history of recent fever. Their presenting visual acuities vary, but the fear in the eyes was the same. Doctor, I can't see clearly. The anterior segment findings were almost normal for all the patient. To understand what exactly was harming their vision, we called upon the saviors of the story. The first one, the fundus finding. We found something common in all the cases. Retinal whitening lesions, hemorrhages, hard exudates, cotton wool spots, vessel exudation, and in one case we also find out neovascular inner retinal layer hyperreflectivity, neurosensory detachments, subretinal fluid, ellipsoid zone disruption, and in some cases neovascularization also. This confirmed that the battle was not superficial. We paused and asked, we needed the technology that sees the unseen. And here comes the heroic twist, the Octa. The Octa told us what OCT was not able to tell us. We found some common findings in all these patients. The green part showing the irregularity in foveal avascular zone, the capillary dropouts, the deeper layer showing the void areas, which was more prominent in the deeper capillary plexus, the void areas, neovascularization, pruning of vessels, beading of the vessels, and shadow artifact because of the superficial edema. Also, we find out reduced perfusion density upon perfused area percent. As you can see in this OCT, it looks almost normal. But the Octa, everything that is marked in red shows reduced, proved its worth. Now it's time for